Morning, members. It is the appointed time and we have a quorum. I call to order the last meeting of the panel on health services of the year. I will now invite the government officials to come in. Meanwhile, we will begin with item 1, information paper issued since the last meeting. The Secretariat has issued one information paper for members' reference, details of which have been set out on the agenda, that is CB-3-862-2024-01. Do members have any views on this paper? There being none, we move on to item 2. We welcome the government official team led by the Permanent Secretary for Health, Mr. Thomas Chan. They are responsible for items 2 and 3. Item 2, the final reports of the Working Group on Oral Health and Dental Care and the reports of the Oral Health Survey 2021. Item 3 is the proposed creation of one permanent directorate post of consultants in the Department of Health to strengthen community oral health care. Please be reminded that we have the same government official team representing the government for the two items. Later on, there will be other meetings held in the complex. While item 2 and 3 are related, if you'd like to state your views on item 3, in item 2, I will be fine with it. That proposal will be submitted to the Establishment Subcommittee. If you are stating your views on the proposed creation of the post, you have to state whether you support the submission of the proposal to the ESC as well. However, item 3 involves an establishment proposal in accordance with Rule 83A of the Rules of Procedure. If member is to speak on matters in which they have direct or indirect pecuniary interests with, they need to declare the nature of such interest first before they speak. That will allow you some flexibility to join other meetings in the complex. Mr. Thomas Chan, ready when you are. Item 2 and item 2, final reports and the reports of the oral health survey. Thank you. In 2022, we established the Working Group on Oral Health and Dental Care to review the existing services and advise the government on the scope of services. The final report was published last Friday, with the strategic recommendations published. Today, we are briefing members on the final report, including the work plan, the action plans formulated by the government. We also seek the support of the panel on creating a permanent directorate position of consultants in the DOH to follow up on the recommendation made by the final report. Now, there are three major policies advised by the working group. First, oral health is an integral part of general health. A policy objective is to help citizens improve their oral hygiene and lifestyle conducive to both oral health and overall health levels. Also, through developing primary preventive oral health care system, we will encourage the public to retain the teeth and manage the teeth health. Also, for the underprivileged groups, we will provide essential care and curative and preventive services. Now, the working group has made reference to the changes in citizens' oral health as well as the past survey. We found that there has been continuous improvements in the general health and oral health of the public. With our preventive measures conducted, children and elderly people and adults' oral health in Hong Kong is at a good position compared with other places in the world. However, there are still some dental disease risks which we need to pay attention to. At the same time, the working group has reviewed the government's provision of curative dental services from public purse. Now, these services have a wide scope covering various age groups. The government has been continuously enhancing the resources allocated to the field. Now, in 2024, 3 to 4, some $1.3 billion have been spent on dental care services. However, it is found that in terms of usage of dental financial resources, we are skewed towards curative rather than preventive approach. And the government hasn't taken a comprehensive consideration on the comparative cost effectiveness of various services. In terms of subsidized dental services, there is not sufficient means to monitor the effectiveness of the services. And there is much room for development in preventive dental care. So the working group advocates to adopt the policy of early identification and prevention as our direction. We will also follow the approach of providing primary services to the general public for different age groups, and also provide targeted service to underprivileged groups. Now, for providing primary services to the general public, we will encourage a healthy lifestyle and good oral health among the public. Now, via DHCs and DHC Express, we will provide primary dental care services to the public. In early 2025, we will launch the Primary Dental Co-Care Pilot Scheme for adolescents. The second strategy is to provide essential dental services targeting underprivileged groups, especially curative services. This includes launching the Community Dental Support Program in the second quarter next year. Towards the end of this month, the Department of Health will launch the online registration system for dental general public session to enhance the arrangement. Also, we will expand special care dental services to further support groups with disabilities, including children with mental disabilities. Now, starting from the 1st of January 2024, we will allow non-locally trained dentists to register in Hong Kong on a limited or full basis. We will also enhance the training quota for dental professionals. Now, we foresee that the demand for dental services will increase significantly. To implement these recommendations and develop special dental care services, we need directorate leadership. Now, the doctor responsible for the work in the Department of Health is very overloaded already, and the work scope is very different from the original scope. That's why we need to create a permanent position of consultants in the Department of Health to strengthen community oral health care in terms of planning, implementation, and strategizing. We seek member support on this. I and my team will do our best to answer members' questions. Thank you. Now, please press the button if you would like to ask a question. Item 2, I would allow 4 minutes, including questions and answers, to members. If you are also speaking on item 3, I will extend the time appropriately. So we have Mr. Kissen-Yang, Chen Kin-po, Chen Pui-leung, Ms. Lam So-wai, and myself, and Professor Chen Wing-kwong. Mr. Kissen-Yang. Thank you. I will speak on both items. First, on the final report. Now, there is the Community Dental Support Program. It includes tooth extraction, dental fillings. This is a new service. I like this additional service. So, at an administrative cost of $50 per tooth, patients can get dental filling services, but there are only 40,000 quotas. I know this is the minimum, and there is room for expanding the quota. But what will trigger that? When will you review the quota level for dental filling sessions? Second, you are collaborating with NGOs and community organizations. Can you also collaborate with private dentists as well? There are not a lot of dental clinics run by NGOs, and they are not evenly distributed across the territory. So will you consider expanding the scope of the program to private dental clinics? Another issue close to my heart. The government said that by 2026, the program would supplant the Community Care Fund Elderly Dental Assistance Program. By 2026, I am very worried. Now, the CCF program also covers denture. So by supplanting the CCF program, it may mean that elderly people will get fewer services in the future. So what about denture? Is that covered by the new Community Dental Support Program? Now, if there is the need for denture service, will the patients be referred to other institutions? Now, there is the co-payments arrangement. The government will pay $200 and the patients will have to pay $200 as well. Can we learn from the elderly healthcare voucher scheme for the Bay Area? Can we sponsor dental patients to seek help in the GBA? The scheme for civil servants and eligible persons have been expanded already. So can you do the same for the elderly healthcare voucher scheme? Now, on creating the permanent directorate post and also the private secretary, I have reservation on this proposal. I don't see any big changes recommended by the final report, and I don't see why the new post is necessary. Now, by 2026, the CDSP Community Dental Support Program will supplant the CCF program, which means that less support will be given to elderly people. So can you explain to me why this new position is necessary? Do we need a directorate post holder to discharge these duties? An executive officer would be more than sufficient to discharge the duties, and you are also assigning a private secretary to the director. It would cost some $4 million per year, so I have reservations given our fiscal position. Permanent secretary. Mr. Tzit-yuen will attend other meetings, so he's asking his question on item 3 as well. Thank you. Now, the Working Group on Oral Health and Dental Care has conducted a comprehensive review on publicly funded or subsidized dental services. Now, the CDSP will come with a number of new services and measures. Now, you may think that all the recommendations or measures are familiar, but that is because they have been announced in the past 2 policy addresses. The details of these measures, however, have been fleshed out in the action plan. This includes providing dental guidance and risk assessment at DHCs and DHC expresses. And also, preventive dental services for preschool children would be extended to children up to 6 years old. And also, the primary dental co-care pilot scheme for adolescents, that is a new program. The CDSP is a new program as well. So I want to emphasize that, first, we are allocating new resources to implement a series of targeted measures to address existing shortfall in our services. However, to make that happen, we need suitable leadership to implement the developments for our dental care and healthcare system. Now, the Department of Health is really eager to improve our dental services. That's why our colleagues have been helping the working group out of their own time to finalize the report and the action agenda. If we are to continuously improve our oral and dental care services, there is a need to designate a consultant in the DOH to supervise the development of the system. At present, there is no such a position. Either the consultants are working for the civil service dental clinics, or they are providing clinical services. Now, the entire oral maxillofacial surgeon department would be integrated with the HA. So 6 clinical oral maxillofacial surgeon posts will be deleted. So actually, we are just redeploying the resources to the provision of primary dental health care as recommended by the working group. So I will invite the Deputy Secretary to supplement.
Regarding the Community Dental Support Program, the members ask about quotas. We are now engaging community organizations and NGOs to submit proposals for the program, and we received positive feedback. We have received proposals from a number of NGOs. The Department of Health is scrutinizing these proposals currently. Hopefully, we can provide 40,000 quotas under the program. After looking into the manpower deployment and the resources, if possible, we want to raise the quotas, but we're talking about at least 40,000 places to be offered under the program. I still have other questions, Chair. On the Community Care Fund Elderly Dental Assistance Program, it will be replaced in 2026. Previously, denture services are covered and is not covered under the new Community Dental Support Program. Will you retain denture services under the new program? I want you to give a clear answer to this question. That's clear enough. A few questions have not been addressed. Maybe you should answer Mr. Yang's question in writing, because that affects his decision on whether to support your submission of the establishment proposal to the ESC. Deputy Secretary, thank you. The Community Dental Support Program also covered denture services and tooth extraction. In the action plan prepared by the working group, it is said that over the past 10 to 20 years, we see that the oral health of our elderly people have improved very substantially. The ratio of elderly having more than 20 teeth account for 80% compared to 50% previously. The percentage of elderly with complete tooth loss have reduced to some 0.9. Some elderly may need denture services because they have suffered from complete tooth loss, but with improvement of oral health in elderly people, the demand for such services has dropped. The working group tries to retain people's teeth and improve their oral health, but under the Community Care Fund Elderly and Dental Assistance Program, we notice some problems. The ratio of tooth extraction and denture is very high. Is that the best way for us to deal with oral problems? Is there a way for us to retain more teeth in our people? Under the Community Care Fund Elderly Dental Assistance Program, we spent $15,000 on each case. Compared to outreach dental care program, we're talking about 10 times the cost. Let me give you a simple answer to the denture services question. Under the Community Dental Support Program, we do not rule out the possibility of providing denture services if it's necessary or absolutely needed. We're not going to provide denture services as long as we see a complete tooth loss. We want to provide a more comprehensive kind of service. We will offer tooth scaling, teeth filling to improve their overall oral health. We will work with NGO to see how we can still provide denture services under the new program. For outreach dental care program, under the program, if necessary, also provide denture services for residents living in RCHEs. If I may remind members who have just come in, as the items 2 and 3 are interrelated and there are other panels, meetings going on in other conference room, you may speak on the third item in this round as well. So each member may speak for 8 minutes max. Next, Mr. Chan Kim-por. Thank you. In 2023, the elderly rolled out this elderly health care voucher to encourage elderly people receive dental care services. I wonder if the voucher scheme is effective, how many elderly people have received dental care using the vouchers. In 2021, according to the oral health survey, I'm glad to see that the overall dental health of our people have improved, but there is one thing that have deteriorated, that is the the proportion of adults and older persons with bleeding gums and gum pockets that has been on the rise over the past 2 decades. I wonder what measures the administration have to control the situation. On the creation of the permanent position of a consultant, I trust your judgment. I think that you do have a mechanism to see if the post is absolutely necessary. But given our fiscal deficit, how should we look at the issue? You said that you have looked at the workload of the 9 consultants that are already at your office, and you said that they are busy enough. You mentioned that 6 surgeon posts will be deleted. Can you explain in detail? I think it's better for you to make internal adjustment, because we need to offer new kind of services still. These are my 3 questions. Permanent Secretary. Thank you, Mr. Chan, for the question. First, on the elderly healthcare voucher pilot reward scheme. Since its launch, there are some 700,000 elderly persons who have spent $1,000 with a voucher on dental care services. On the issue with bleeding gums and gum pockets among adults and older persons, we've looked into the issue. Although the oral habits of adults and older persons have improved, they brush their teeth, for example, 2 times a day. But for the use of other dental cleaning tools or devices is lacking. So the working group sees a need to ask the members of the public to receive regular dental checkups, because by then they will know if they have any issues with their teeth, and they will be taught how to use interdental brush and dental floss to avoid the deterioration of gum disease. So for adults, we work with employer groups to see if they can encourage their employees to receive regular dental checkups. And together with the Dental Council of Hong Kong, we're working on a program to provide regular checkups for adults and older persons. We're looking into creating a program that is like primary dental co-care pilot scheme for the adolescents to incentivize regular oral checkups. For the reward scheme, that is the elderly healthcare voucher pilot reward scheme, the response is great. But together with the dental sector, we'll see how we can further encourage elderly to receive oral checkups regularly. As for the position of consultant to be created, under the Health Bureau, we have one consultant on child care services is necessary because we have school dental care service program. We have 2 principal dental officers, one responsible for school dental clinics, the other is responsible for the dental service administration office, that is also the dental registration ordinance. We also have an oral maxillofacial department. We have 6 consultants under the department. And in the future, these 6 consultants' positions will be deleted. After these positions are incorporated under the surgery and dental clinics instead. Under the action plan, we think that it's necessary for us to create a post of directorate consultant to lead the entire dental or community dental service under the Department of Health. Next, Mr. Chan Pui-lan. Thank you, Chairman. Or thank you, Madam Chair. Well, for the strategies to provide primary services to the general public and to provide targeted services to underprivileged groups, I support all of them. I'd like to ask about paragraph 20. It is said that a pilot scheme will be rolled out to fill the gap for adolescents aged between 13 and 17. This currently they cannot receive free dental services. Can you elaborate on the entire primary dental co-care pilot scheme for adolescents? How much do they have to pay under the co-payment arrangements? On promotion and publicity, especially for school dental care services, I wonder if you have any targeted promotional strategies for the parents. Well, for the creation of posts, I have some questions because the government is having a fiscal deficit. We have to be careful before we create any permanent post. The consultant will take the leadership position in giving directions. And I see that you have a principal dental officer under the Dental Regulatory and Law Enforcement Office. Is the workload of this officer not heavy because usually it's the police who will take the enforcement action. The regulations have already been set. Perhaps this PDO will only be responsible for overseeing the regulations. Will that post holder be able to take up the work of this proposed consultant? Why are you creating a permanent position instead of a supernumerary position? I think that you should create a time-limited post instead, so that after the deletion of the surgeon post, you can create this permanent post.
主席，多謝。
Permanent Secretary, please. Thank you, Chair, and thank you, Mr. Chan. On the last question, the final report of the working group and also the action plan formulated by the government highlights the government's long-term commitments to dental health care. We need a long-term plan to develop the system and implement the measures. Now, some members ask whether we will extend the scope of the community dental support program and adjust the service scope of some special care services. These we will do. But we still need a leading figure in the entire system to lead the development of the system according to the recommendations. Concerning publicity, an education campaign, and also the existing distribution of work within the Department of Health, I will invite Dr. Kitty Chui of the Department of Health to explain. Please switch on Dr. Kitty Hui's mic. Thank you, members, for your questions. Mr. Chan asked about the dental care services for children and adolescents. What can we do more to enhance publicity? Now, in the final report, you can see how we are going to plug the gap in the shortfall of our services. For example, at present, the students' dental care program only covers students between the age of 6 to 12. So there is a gap for children, preschool children, aged up to 6 years. That is not comprehensive enough. From the report, we also found that for children below the age of 6 or even 5, their dental health situation is worrying. Some 40% of the children in that age group have tooth decay. So we'll shift our focus to preschool children aged up to 6 years. We will work with Maternal and Child Health Center to launch the Loving Smiles service. This is a new service. We will proactively reach out to mothers and babies at Maternal and Child Health Center to offer tooth assessment services to the babies and provide guidance to the mothers. Also, we are going to work with kindergartens and provide oral assessment for kindergarten pupils in all kindergartens. We already have a scheme working with the Hong Kong Jockey Club. At the primary school level, we have the primary school students' dental care program. And also, it is found that Hong Kong's youth aged between 12 and 13 enjoy the highest level of oral health in the world. Now, we are going to extend our students' dental care program to the secondary level so that secondary school students can enjoy dental care and oral assessments in the private sector. They would also be given professional guidance on toothbrushing by dental hygienists. Now, it is a common misconception that toothbrushing is simple. However, it is not as simple as that. You need to work the brush into the gaps. So from 0 to 18 years of age, we are going to improve the dental care for the young persons, and then that would translate into better oral health for adults as well. Now, about the principal dental officer, they are responsible for regulatory work. They are responsible for issuing licenses to dental clinics and daycare centers. So by the end of next year, all dental clinics will need to get a license from our regime. So this not only covered unlicensed practicing of dental services. Deputy Secretary, please supplement. Thank you. Concerning the fee level, we align that to the chronic disease co-treatment program. That is a co-payment model of $200. So same for the primary dental co-care pilot scheme for adolescents program. Now, of course, the participating dentists can set their own fee level, but the principle is to be transparent and fair. So that parents can select services under a transparent model. Under the program, there is tooth scaling and oral check services. If subsequent procedures are required after the checkup, for example, X-ray and tooth scaling and tooth extraction and so on, the fee would be communicated to the parents in advance. Now, $200 cover tooth scaling. Besides that, tooth extraction and tooth filling, the price would be communicated to the parents by the participating dentist transparently. Ms. Lam So Wai. Thank you. Now, this final report is marvelous. When I was younger, I participated in youth dental volunteering program organized by the DOH. I think the final report is an upgrade compared with the past. Much attention is paid to young people, elderly people, and also people with special needs. We have the primary dental co-care pilot scheme for adolescents program, so I applaud the government's efforts. Still, I would like to follow up on the question. That is a question asked by other members as well. That is the Community Care Fund Elderly Dental Assistance Program. Now, the administration said that each case would get $15,000 in subsidy. Now, in the future, NGOs will be invited to participate to provide denture services under the CDSP program. Now, I understand that many NGOs are interested. They have already drafted a proposal. Now, since we have the plan laid out, we need to look forward. When we are outsourcing the services to NGOs, how will that work? Frankly speaking, the perception of the public on dental services provided by NGOs was diverse. Some are very popular and some are of very bad reputation. Now, I have referred some elderly patients to some NGOs to receive dental care services, but the elderly people would refuse because of the bad reputation of the NGOs. Also, now you are supporting dental care services from the age of 0 to elderly people. That's great, but I have reservation on the proposed creation of the new position. Honestly, we have a serious fiscal deficit right now, but you are asking for $4 million a year to create the directorate's post plus a private secretary. That's a personal secretary we are talking about. I understand that they need to take forward the amended dental registration ordinance. But there are already 11 directorate posts within the DOH in the dental discipline. We need to tide over these difficult times with the society. Now, there are already talks asking for the government to freeze civil service pay. Now, we are reforming a lot of our services and our system as well. So can we be more flexible in reforming the manpower position of the Department of Health? Can we assign the civil servants to be the coordinating officer to take forward the relevant work? Now, the intention is good, but the work is mostly about coordination and negotiation. Do we need such a high-level directorate's position to be taken by a dentist? Permanent Secretary, thank you, Ms. Connie Lam, for your question about the creation of the post. Here are some background. Now, in year 2023 to 4, the amount of resources allocated to dental services amounted to $1.3 billion. The working group, however, identified a problem. Say, for example, CCF, Elderly Dental Program, and Elderly Healthcare Vouchers Scheme. After outsourcing these services, there is not a mechanism to monitor the efficiency of use of resources. Now, the problem of focusing on cure rather than prevention arises from the lack of a dedicated personnel to monitor the working of the system. Concerning the new programs and new services, we expect that an additional $100 million will be allocated to these services each year. In order to take forward the new services and ensure effective use of existing resources, there is a need to have a directorate-grade officer in the Department of Health to oversee the development of the new programs and the entire oral health care system. Now, as I mentioned, under the Health Bureau, dentists of directorate grade are not providing clinical services. For example, dental care for children with special needs and so on. They are working on legislative changes. As we said, after reforming or rationalizing the services under the DOH, we will delete 6 consultants oral maxillofacial surgeon posts within the Department of Health. Now, through service integration, we are able to do that, and we are just asking to create one directorate-grade consultant to take forward the development of community dental support program. So we think this is a commensurate use of resources. Maybe I will invite the Deputy Secretary to supplement the details about a community dental support program. Mr. Lee, thank you. I thank Ms. Lam for her support. Now, the idea of the CDSP is to collaborate with NGOs in delivering existing services to ensure that we can provide community primary services to the general public and targeted services to the underprivileged. Now, there are some groups which we have trouble reaching out to, for example, the homeless people and also those living in poor living environments. So we would like to reach out to them and fill the gap of services. Concerning the quality of services, in our design, supervision is key. We need to create a new position because we need someone to oversee the delivery of the program. Now, the CSDP is a new program. The CDSP is a new program. When a lot of NGOs are involved, we need a clinical dentist to lead the group to ensure that the quality is up to standard.
Professor Chen Wing-Kong. Thank you, Madam Chair. I have two questions. For the strategies proposed by the working group, that is to provide primary services to the general public and emphasize prevention, early identification, and timely intervention, as well as to provide targeted services to underprivileged groups. I support them. I'd like to ask about the Community Dental Support Program. What is the capacity of the program? How many people will benefit? What is the estimates? 40,000 quotas, is that a ceiling? Is there room for adjustment? The administration said that on the 30th of this month, the online registration system for dental general public session will be rolled out. A lot of elderly people are worried if they will be able to book a general public session. How are you going to help people who don't know how to surf the internet to make a reservation so that they can receive general public services? On the creation of the post of consultant, I have a question. The administration is trying to create a permanent consultant post to enhance community-wide preventive primary oral health. According to paragraph 10 of the paper, a lot of programs listed are extension or continuation of existing programs and schemes. All these schemes are similar to Community Care Fund Elderly Dental Assistance Program. And for the Primary Dental Co-Care Pilot Scheme for adolescents, we can make reference to the school dental care service. So the programs are not brand new. Given our $100 billion of fiscal deficit, I like to ask if the administration should ask the existing consultants to take up the work. The administration spent a lot of paragraphs on the duties of the proposed consultant post, but they've not set out any key performance indicators for the post holder. If the establishment proposal is approved, how are you going to enhance the quality of dental services in the community? Can you highlight the importance of this position? Permanent Secretary. Thank you, Madam Chair. Thank you, Professor Chan, for the question. Let me first talk about the creation of post. If I may clarify, for the programs that we talked about, such as the Primary Dental Co-Care Pilot Scheme for adolescents and the preschool dental care services, the Community Dental Support Program, all of these are new. In the paper, we said that we're already working on it because we want to formulate the plan first for it to be rolled out in 2025. These are extra schemes and programs on top of the services that we are already providing. That's why we think that if we are to launch the Community Dental Support Program, we need a colleague that is dedicated to follow up and lead it. That's why we need this position of a consultant. As we mentioned, we will dedicate more resources into providing dental services, and that's why we need also more manpower. As for the Community Dental Support Program, I will ask the Deputy Secretary to elaborate. As for the public session, Mr. Lee will supplement. Thank you. On the Community Dental Support Program, CDSP, there are a few improvements. First, the capacity will be improved. Currently, we can only offer 20,000 general public sessions. Under the CDSP, the capacity will be increased. We try to provide 2 times more sessions for the general public. Hopefully, we can offer 40,000 public sessions. And for the 20,000 general public sessions, quotas discs, they will be retained. And the service scope will also be extended. As you all know, only tooth extraction and pain relief will be provided under the general public session of the Department of Health. In the future, the scope of service will be increased to also cover dental fillings. And this is in line with the report of the working group. We should avoid tooth extraction as far as possible. Third, we will be more proactive. As we mentioned, we work with the NGOs under the CDSP. We want to reach out to people that we weren't able to, as well as those who are reluctant to receive dental services, including the homeless and those with disabilities. So this is a new and improved program. Dr. Hui. Thank you. Let me talk about general public sessions of the DH. On the 30th of December, we will launch the online registration system for dental general public session. We know that some elderly people don't have mobile phones and they don't know how to use the system. We will assist them. First of all, you can only book a service for tomorrow. So at 6 a.m. to 11:30 a.m. each day, we open the system for interested parties to make a reservation. For those who don't know how to make reservations or don't have mobile phones, we do have a community network for support. Together with the 18 district health centers and expresses and the district counselors' offices, community care teams, and the HAD elderly centers, within this week, we have provided for online trainings attended by some 500 participants. We see that these training sessions are very popular, and the welfare sector is passionate in helping people in need. The most important thing is that if there is no one that can help the elderly person, we ask the relevant person to actually walk to the general outpatient dental clinics. Our trained colleagues will help the elderly person to use their mobile phones, if any, to make a reservation. If they don't have a mobile phone, we will use our tablets to help the relevant person to make the reservations. This service is very popular, and I believe that elderly people in need will be helped. If I may remind members that have just entered, as there is another panel meeting next door, the second and third item on the agenda are interrelated, so you can speak on the third item as well. The total speaking time will be 8 minutes. Thank you. Next, Dr. Sari Lee. Thank you, Madam Chair. I think that we all support the report of the oral health survey. People of all ages are covered. Given our limited resources, we all believe that there is issues for school dental care services and children dental care services. They are comprehensive enough, I believe, because we have a low birth rate and we also have school dental care service. So I'm not worried about the oral health of our children or adolescents. But I think, well, that's why I think that we should focus on elderly people. I know that there is difficulty. I see that the oral health of the elderly people have improved, and it is said that you can use elderly healthcare vouchers in the mainland, and there are 331,000 dental care reservations being made. For this group of elderly people, when they were young, they weren't used to caring for their teeth. A lot of them have periodontal diseases. Even with the general public sessions, their issues cannot be dealt with. Some of them need dentures. And they have to really fix their teeth to a great extent before they can use their teeth properly to eat. I think that you should inform the elderly people that they can use their elderly healthcare vouchers in the mainland. I know that we cannot cover people of all age groups because medical services are expensive. But at least I think that you should let the elderly people know that there are different ways for them to solve the problem. For grassroots elderly people, they don't even dare to go for private dentists. Even I cannot make a reservation for scaling services in private clinics. And denture services is very expensive here. Even if the family members are willing to pay, some elderly people don't want their kids to pay such a high cost. I think that you should give the elderly people more choices so that they can use their teeth to eat properly. Permanent Secretary. Thank you, Dr. Lee, for the suggestion. Let me give you some background information. In 2023-24, the government has dedicated $1.3 billion in dental services. Most of them are spent on elderly people. For elderly healthcare voucher, pilot reward scheme, and the community care fund, elderly dental assistance program, they amount to some $800 million. So now money has been spent, but are they well spent? Even before the final report has been promulgated, we have taken several actions. First, we have this elderly healthcare voucher pilot reward scheme to encourage elderly people to make use of preventive primary dental care services instead of just seeking for tooth extraction when they suffer from pain. Starting from the middle of this year, we have relaxed the service scope of Community Dental Support Program and the subsidy. If elderly people want to go for dental scaling or fillings, we subsidize them under the Community Care Fund Elderly Dental Assistance Program. For elderly people with financial difficulties, even after the Community Care Fund has been replaced by the CDSP, we will still support them. The member asked if we will continue to provide denture services under the CDSP. Well, according to the suggestions given by the working group, we want to instead now focus on prevention instead of curative services. We want to provide a comprehensive dental services from prevention, simple treatment to denture services. Thank you.
I understand the importance of prevention, but you must understand that many elderly people have no teeth at all. Prevention doesn't help. You need to give them immediate help. Give them affordable denture services so that they can eat normally again. That is how you can help them. Prevention doesn't apply here. Now, there are two other programs to achieve what you said. However, according to the oral health survey, tooth loss or complete tooth loss among elderly people have improved significantly 2 decades ago. Back then, half of the elderly population had no teeth. Now, 80% of our elderly people have more than 20 teeth. Now, for those who have lost all the teeth, the percentage has dropped to 0.9%. So the need for elderly people to receive denture implants has reduced significantly. Starting this year, we are extending the elderly health care voucher scheme to the Bay Area. That provides the elderly patients with more choices. Also, their health record can be assessed by the service providers in the mainland via the e-health. So we are increasing the service points under the GBA Elderly Healthcare Voucher Scheme to allow the elderly people more choices. Now, the core issue is our manpower. The Dental Academy has increased its training quota from 30 to 90 annually. And there are some simpler tasks which do not require dentists. For example, oral health guidance or assessment. We would like to give more play to oral hygienists and dental hygienists to deliver these services so as to enhance our primary dental services. I think Ms. Starry is asking you to not neglect the 0.9% of the elderly population who have lost their teeth completely. So maybe you can reach out to Ms. Starry after the meeting. Next, Ms. Judy Chen. Thank you, Chair. First, I'm pleased to see a lot of new programs coming online. They should be able to address the long-standing demand for better oral care. Now we start with young people. I'm quite surprised that some 40% of preschool children experience tooth decay. That number speaks a lot about the severity of the issue. Now we are facing the problem square on. That's good. If you look at the tooth decay without treatment among adults, the ratio, the percentage is one in every 3 adults. So I would urge you to be greedy. Why don't we ask the children to educate their parents as well? Now you have a slogan this year that is, if you love your teeth, you should do a checkup every year. Now that is a good slogan, but you can make it even more appealing, make it catchy so that the children can urge their parents to do a dental checkup every year. So I don't know whether you have the resources to conduct free dental checkup for adults as well. But maybe some incentives will go a long way. That's worth considering. The parents are going to turn old in 1 or 2 decades' time. So in terms of prevention, don't neglect the adults. So I fully support your efforts with young children. Now about elderly people, now the Permanent Secretary mentioned that we have fewer and fewer elderly persons requiring denture. So the figure is improving. However, no one would like to use denture if they have genuine teeth. So let's not set the threshold or eligibility threshold for receiving denture services too high. I know we have limited resources. We are also taxpayers. With the poor fiscal position, many taxpayers are worried. But there is a sizable group of elderly people who require denture. We should provide this service on a need basis. I also have a question about the application of our healthcare vouchers in the mainland cities in the Bay Area. In choosing which dental clinic to go to, do we provide sufficient information to the elderly people about quality dental clinics? Do we have a list of quality clinics in the GBA for the elderly people? What about the third item? You have spent 4 minutes already. Maybe you would like to hear the answer from the administrator as well. Permanent Secretary, please. Thank you, Ms. Judy Chan, for your question. I will first invite Dr. Kitty Hui to explain how we are enhancing dental care services for preschool children as well as education. Dr. Hui. Thank you, Ms. Judy Chan. Now, the Loving Smile service is extended to maternal and child health center. So while providing oral assessment services to the children, to the babies, we will not neglect the mother as well. We will provide oral health education to the mother. Not only that, after providing the assessment services, a dedicated case manager would follow up on the situation of the mother and the baby in 12 months' time to learn about difficulties encountered by the mother in caring for the dental health of the baby. In 1 year's time, the baby would have a lot more teeth grown. So under the CDSP, we have an oral health promotional unit. They are responsible for promoting oral health among preschool children, young children, adolescents, adults, and the elderly. We will continue to organize oral health activities for these age groups. Now, with the unit subsuming under the CDSP, they will be better positioned to deliver these services. About elderly denture, as mentioned in my previous replies, under the future CDSP, underprivileged groups with financial difficulties, including the elderly, will be able to receive denture services even when the Community Care Fund Elderly Dental Assistance Program is supplanted. But that is a limited service. Now, what the working group has identified as important is that we need to help the public to keep and retain their teeth. So for the CCF program, most elderly people would come and ask for denture. However, for some 20% of the cases, even with denture, it doesn't help much in terms of the eating. So that's a waste of resources. Now, when there is a clinical need to provide denture services, we will still provide the essential services to the elderly patient. However, it is up to the clinical judgment of the dentist to find the best solution for the dental problem. Mr. Lee, about the dental clinics in the GBA. Thank you. First of all, under the pilot scheme, we have conducted an investigation on site. The dental clinics and the comprehensive hospital and the composite hospitals with dental services we have selected are of a very high quality. Ms. Judy Chan has also visited these clinics with us. So I believe that there are actually quite a number of choices for elderly patients. Chair, if I may, for dental clinics not on the list, is there any way that you can prohibit them from putting out advertisements or commercials in Hong Kong? Deputy Secretary. Now, in terms of regulation of dental clinics on the mainland, that would be up to the mainland authority. For advertisements put out by these clinics, there are separate regulations on both sides. Mr. Kingsley Wong, thank you. Oral health is very important. Tooth pain is the worst. And when you see elderly people with good teeth, usually they would smile more and they are happier. So I have two questions. First of all, you say you're going to focus on provision of essential services to the underprivileged. Now, there are some recent surveys that we have 1.4 million people in poverty in Hong Kong. So how can we define those in poverty? Do we define them as recipients of CSSA, those living in SDUs, and so on? How can we be more targeted? How do you define people with financial difficulties? We need to ensure that no one in Hong Kong is not getting essential treatment because of financial difficulties. Also, your strategy is early identification, early prevention, early treatment, and prevention. So a lot more manpower will be required. So would the government consider distributing healthcare vouchers to designated groups so that they can get treatment from the private sector? Now, with more and more people getting dental services in the mainland, we have a lot more capacity in the private sector in Hong Kong. And also, what about sponsoring these patients to receive dental treatment at designated institutions in the mainland? It's a financial viewpoint. The dental services in the mainland are much cheaper than those in Hong Kong. So for those with financial difficulties, can we encourage them or incentivize them to use the resources in the GBA so that there can be more efficient use of resources on both sides? We need to make sure that our money is well spent. When there is a fiscal deficit, if a dollar can wealth more on the mainland, that would be a great. Now about manpower. In the Department of Health, there are 11 directorate-grade dentists. Again, fiscal deficit. Can we ask each of these dentists to do a bit more to share the burden? Now, the principal dentist, that is very expensive. Can we ask a senior executive officer to handle the workload? Fiscal deficits, we need to cut spending on manpower.
多謝黃議員。
Permanent Secretary. Thank you, Mr. Wong, for the question. For CSSA recipients, under the CSSA, they have dental care subsidy. For the Community Dental Support Program, we target non-CSSA recipients with financial difficulties. Who do we cover? Those who enjoy medical fee exemption under the hospital authority public system, and those who receive community care fund. I know that there are different groups that need our support. What about recipients of working family subsidy, allowance? The reason why we work with NGOs under the Community Dental Support Program is because most of these NGOs have a network already. For working poor and the homeless or those living in subdivided units, we see that a lot of welfare organizations are already taking care of them. We want to leverage on the service network of these NGOs so that we can offer dental services to the underprivileged. We think that this will make our program more targeted. Instead of having us identify this group of underprivileged groups on our own, this is our major consideration. For elderly healthcare vouchers, EHCVs, people can make use of the vouchers on the mainland. By this, we are giving them another option. We also have service points in Shenzhen. You'll see if we will expand the number of service points on the mainland. I think that is more pragmatic for us to have NGOs refer services. So through registered social workers, we want to identify the underprivileged group that we want to help. As for manpower, I will ask my colleague to supplement. But as I mentioned, and also is stated in the paper, that eventually there will be 6 consultant surgeon posts being deleted eventually. So in other words, we're deleting 6 posts for clinical services because of the restructuring of service framework and staff redeployment. At the same time, we're only creating 1 consultant position to take forward the recommendations put forward by the working group. We've covered a lot of programs previously, so the workload of this consultant is heavy. Mr. Hui. Dr. Hui. Thank you. We want to create this position because we want to take forward the programs and schemes recommended by the working group on health and dental care. We need someone who has undergone specialist training in community dental service. Just now, members asked if we can engage an administration officer to take up the post. But without training in community dental service, the post holder will not be able to take forward community-based dental care programs that we're offering. So I hope that the members will support the creation of the position. We have exhausted our resources to take forward the recommendations put forward by the working group. As mentioned, we need to identify underprivileged groups and people. I hope that the members will support the creation of the position. The Permanent Secretary did not answer you if recipients of working family allowance will be covered. Is that right? Yes. We talked about referrals made by registered social workers for recipients of working family allowance through the relevant NGOs. The case may be referred to the Department of Health by the registered social workers. So not all recipients of WFA will be covered by the program. That's true. But through NGOs, we try to identify people in need because we want to leverage on the network of NGOs to identify underprivileged groups. So not all recipients of working family allowance will automatically be covered by the program. For recipients of working family allowance, they are low-income families. Shouldn't we have them automatically eligible for the program? Permanent Secretary, please check the issue with the LWDB. We will seek advice from the Labor and Welfare Bureau. Next, Dr. David Lam. Thank you. I'd like to follow up on what Mr. Kingsley Wong talked about on the working family allowance. The administration said that they will rely on the assessment of social workers instead of looking at whether they receive working family allowance. So what criteria should the social worker adopt to assess whether someone is underprivileged? We have so many organizations, we have so many social workers. Will you set a clear guidelines and criteria for the social workers to make their judgment? Dr. Hui said that for us to take forward recommendations set out in the final report, we need someone who is experienced and trained in community dental service because the consultants have to look at the actual need of the people before making any decisions. I have a few questions for the administration. We'll offer general public sessions of dental services to the public, and we also have a CDSP, and that will supplant the Community Care Fund Elderly Dental Assistance Program. And the elderly people also have elderly healthcare vouchers. I'm not sure about the relationship among these three programs. For elderly healthcare vouchers, they serve the elderly people and to provide primary dental care services. But what about general public session? They serve people with financial difficulties. Most of them are elderly. The service scope is pain relief, tooth extraction. Department of Health will be providing the service. For a community dental support program, they also serve the underprivileged, including elderly persons with financial difficulties. So it seems that the CDSP and the general public session are serving the same group of people. Under the CDSP, they also provide tooth extraction, dental fillings services. Is the dental filling service the only difference between the CDSP and the general public session? Say if someone has a periodontal disease and they need the denture bridge, should they pay the charge or fees on their own? The CDSP involves NGO, and you said that you will utilize NGO's organization network to identify people in need. But not all NGOs has experience in delivering dental services, and it will replace Community Care Fund. The Community Care Fund program is supported by professional dentists. If you don't include private dentists under the program, then elderly people have nowhere to seek services. And there is no support for adults aged over 15 years old. And you only try to encourage the employer to provide regular checkup subsidy for their employees. It seems that there is a gap. Why don't you allow the private practitioners to join the program? Why does it have to be NGO who are going to provide the service? I don't understand the constraints. Permanent Secretary, I will ask the Deputy Secretary to supplement. Thank you. Let me first talk about the CDSP. Just now, the member asked if there is criteria for the social workers to make referral. We are now collecting proposals after assessment. When we have identified the NGOs and social welfare organizations that will work with us, we will work out the details of the referral mechanism. But there are a few principles. First, we don't want complicated administrative procedures. Second, we want to retain flexibility for the referral, because now in the social welfare sector, some NGOs work on homeless and some are dedicated to work on people in subdivided units. Some community organizations may have experience in delivering dental services, but they may not have any experience in working with the homeless. We hope that there will be an effective referral mechanism. Why private practitioners are not allowed to join? Well, currently under the Community Care Fund Assistance Program, we rely on the Dental Council of Hong Kong. Well, as Dental Council of Hong Kong is a non-government professional organization, we welcome the participation of private dentists. Well, in community dental services, we focus on a few areas. First, for public session, as you mentioned, we offer emergency pain relief and tooth extraction services. But under the CDSP, we target and focus on those with financial difficulties or special needs. We want to identify them and offer comprehensive services from dental checkups to pain relief, x-ray, scaling, dental fillings, and so on. That's how we want to provide targeted services to underprivileged groups. We want to dedicate more resources to this group of people. Compared to general public session, well, everyone can make reservation for that. In the second quarter of 2025, we're going to launch the Community Dental Support Program. We want to provide at least 40,000 quotas. After that, we will look at whether we can actually identify those who are the most in need for dental care and dental treatment. We will look at the cost effectiveness of the program. And we will continue to review if there is possibility of expansion.
Thank you. So Dr. Lam's other follow-up questions we have to be dealt with after the meeting. Now this is my turn. I know the administration and the Department of Health are working very hard to improve dental care standard, and we are seeing progress. But my opinion is that the final report of the working group is not targeting the root cause of the issue. We are still tapping from the same pool of manpower, the same pool of dentists. Structurally, we are not seeing any improvement. Yes, we have fewer elderly people with tooth loss, and preschool children are enjoying better tooth health, but there are only some 2,600 registered dentists in Hong Kong. The ratio is 0.3 dentists per 1,000 population. Compared with all other advanced cities, the ratio of ours is the lowest. If you are just citing the reduced number of elderly people with tooth loss, that will not improve our manpower situation. So we need to improve our structure. Dental care general public session is a benefit for civil servants. If we don't change the structure, the number of quota under the general public session will still be small. Now, civil servants are people with means. We are trying to help those without means. For civil servants with means, can we subsidize them to seek help in the private sector? Also, there are recognized dental clinics in the mainland of a certain quality. If civil servants can be subsidized to receive help in the mainland, that will free up space under the general public session arrangement for the underprivileged. Now, besides dentists, there are only 266 dental therapists in Hong Kong. Now, do you have a timetable to increase the number of these professionals? You said the number of these professionals will be increased by 2 times. But should we be more aggressive so that we can extend their services to secondary school students or even university undergraduates? There is a serious gap in service. Now, after the primary school years, parents need to pay up for the primary dental co-care pilot scheme for adolescents to get dental services for their adolescent children. So we need a structural change. We need to extend the preventive student dental care program to older children. Now also, even with the non-locally trained, even with the influx of non-locally trained dentists, it is not possible to increase our manpower pool significantly in a few years' time. We have a serious lag in the number of dentists and dental professionals, we are just tapping from the same pool of resources. So maybe we need to change the structure or even the structure of the curriculum of dental students. Thank you, Ms. Chen. We agree that manpower is the crux issue of the entire system. In terms of training for dentists, we have always been reviewing the demand and supply for dental services. Now, the quota of training places in 2023 has been increased to 290. That is because we expected a surge in demand in the future. We will also conduct a manpower projection soon. Now, the additional training places will only be available gradually in a few years' time. More recently, after the amendment to the Dental Registration Ordinance, starting from the 1st of January next year, through limited registration and special registration pathways, qualified non-locally trained dentists can practice in Hong Kong. The Department of Health is conducting the recruitment work. For suitable candidates, we are going to match them with NGOs providing dental services for the government so as to relieve their manpower position as well. Now, Ms. Chan is right. Dental professionals, including dental hygienists and dental therapists, they are also core components of the dental care system. The final report also mentioned that more roles should be given to these professionals. So after the amendments to the Dental Registration Ordinance, some changes involve the introduction of a formal registration system for dental hygienists and dental therapists, and there will be clear definition for tasks performed under the instruction of a dentist or in the presence or in the absence of the dentist. Primary oral health care services can be provided by these dental professionals on the instruction of a dentist, even in the absence of a dentist. That will allow dental professionals to share the burden of dentists. We are gradually improving the training quota for dental professionals. Now we have enhanced the training quotas for dental professionals at the University of Hong Kong. Also, we have been doubling the training places under the Academy of the Department of Health. We're also going to work with training institutions to increase training places according to market demand. For dental therapists, the Department of Health is their main employer. Now, many dental therapists were former dental hygienists who have undergone additional training. So we are going to encourage more dental hygienists to undergo training to become dental therapists. Thank you. Now, members have also spoken on their position on the creation of the permanent directorate post of consultants in the Department of Health. Does the permanent secretary have anything to add concerning item 3? Thank you. Now, allow me to elaborate. The creation of this consultant's post is for following up and implementing the recommendations made by the working group and also the Oral Health Action Agenda. Now, the valuable views given by the members just now will also be followed up by the designated directorate grade consultant. They will be responsible for coordinating the implementation of the measures. At the same time, within the Department of Health, 6 directorate grade consultants dentists will be deleted because of service restructuring, and also the integration with the oral maxillofacial departments. So these posts will be deleted from our establishment. That is why we consider that the creation of a permanent directorate post of consultants to take forward the action agenda is appropriate. Mr. Tommy Zhang, about the creation of the post. I remind members that you need to declare interest if you have any conflict of interest. Now, set aside the issue of fiscal deficit. Over the past decade, whenever the Liberal Party heard proposal to create permanent posts, we would be very concerned. Over the past 2 hours of discussion, we appreciate that there is a serious shortage of dentists as well as dental professionals. I don't see what this new post holder can achieve. Now, my question for the Permanent Secretary is as follows. Is this a one-for-one exchange? That is, are you deleting another post and creating a new one? And also, there is a personal secretary attached to this director. But I think this is too much expenditure. So if you ask the Liberal Party, we have a reservation. We don't think we need a permanent post. We agree that you need to step up work on provision of oral health services. But what we need is more dentists who can improve the oral health of people of all ages. Now, if we can do that, maybe that would be an appropriate time to create a permanent post. So I have serious reservation. Permanent Secretary. Thank you, Mr. Zhang, for your question. As I have explained just now, while we are proposing the creation of this post after the restructuring of the Departments of Health, we are going to delete 6 directorate posts. Now, it is not deleting one and creating one. It's not as simple as that. But we have immediate need to have this new post holder to take forward the new programs. For example, the primary dental co-care pilot scheme for adolescents and the community dental support program. A lot of follow-up work is needed, and coordination with NGOs and private dentists are also necessary. In addition, there are a lot of recommendations and follow-up advice on improving the dental healthcare system in the final report. If the new post is not created timely, that would be a big problem. We are going to delete the 6 directorate posts in the oral maxillofacial department gradually, and that would affect the implementation of the work. Now, I have been serving on the Legislative Council for 25 years. I've heard numerous times that if you give me your approval, we will deliver such and such. I'm not doubting you. I'm just traumatized by my experience. So I don't think you can convince me. I would support a supernumerary position. The Liberal Party would support a supernumerary position. When the 6 posts are deleted, you can come back to tell me that we need to create this permanent position. You can come back then.
Mr. Chan Kim Park. Thank you. After hearing the explanation, I support the creation of the position. We have to decide if we support the administration submitting the establishment proposal to the establishment subcommittee. Most members said that they support or have reservations about the proposals. No one objects to the submission of the proposals to the ESC. So I think that I would suggest the administration to submit the proposal to the ESC. But as a lot of members have reservations about the proposal, perhaps prior to submitting the proposal to ESC, you have to do more persuasion and lobbying work. Next, I'd like to invite the government officials to enter. Next item, hospital authorities review of the management of public hospital system. The administration submitted 2 sets of paper. One on the hospital authorities review of the management of the public hospital system, and the reply given by the administration on the manpower issue. Would the administration and the Department of Health colleagues come in first? I think that we've all read the paper, so perhaps you can briefly talk about the paper and allow the members to put questions as soon as possible. Thank you. Madam Chair, although we have an international and efficient public hospital management systems, given our aging population with the prevalence of chronic illnesses and the increase of medical costs, these have posed pressure to our medical system. We must reform and continue to improve to make sure that the efficiency, the safety of our medical services is stable. On the 21st of June, in light of a few incidents, we have asked a review committee to look into different aspects, including distribution of responsibilities, operations, risk management, and so on. And we have formed a review committee on the 2nd of July 2024. They conduct in-depth review on governance, appraisal, accountability, and distribution of responsibilities, operation, risk management, and procedural compliance, covering and more involving multiple levels ranging from HA head office to hospital clusters, hospital departments, and staff. They have conducted cluster visits. They have met with frontline officers, the HA management, and patients and their families. And they have submitted the report to the HA head office. They have made 31 recommendations. The HA management had looked into the report, and on the 8th of October, they have submitted the action plan and the report to the Health Bureau. I thank the experts of the review committee for their efforts. After looking into the report, the Health Bureau agreed to all of the 31 recommendations set out in the report and the action plan proposed. And we also asked the hospital authority to implement all of the recommendations in a timely manner, and they should continue to review the efficiency and effectiveness, and they should submit a progress report to the Health Bureau. Regarding the 31 recommendations, the CEO of the hospital authority will brief members on that. The reports clearly point out that hospital authority, as the largest and most complex healthcare systems, they have been able to maintain the reasonably good safety records amidst enormous challenges. The rate of reported sentinel event is lower than UK, US, and Australia. But as President Xi Jinping said, health is the most important indicators of happiness. In the 3rd plenary session, it is said that we should focus on the reform of public healthcare system. And there is always room for improvement. So we have directed the hospital authority to enhance their management and their systems. The hospital authority will establish governance structure reform committee under the HA board, with the chairman of the HA board, Mr. Henry Fan, chairing the reform committee to steer the implementation of the recommendations made in the review report regarding governance, accountability, and distribution of responsibilities. With a view to ensuring that public healthcare systems can provide the public with healthcare services with quality, the Permanent Secretary for Health and Undersecretary for Health will become members of the Reform Committee. The Health Bureau will continue to follow up on the implementation of the recommendations to enhance safety and actively pursue reforms to improve services with a spirit of innovation and change. Madam Chair, I will now defer to Mr. Tony Ko, Chief Executive of the Hospital Authority, to make a presentation. The speaker is off mic. Please allow us to just put questions. We have read the papers. If the members have already understood the paper, then perhaps we should allow members to speak and take questions. For those who would like to put a question, please press that button. Mr. Chan Kim-por, Dr. David Lam, Mr. Michael Tian, Ms. Lam So-wai. Mr. Chan Kim-por, thank you. I think that the report has pinpointed the crux of the problems, and they have set out 31 recommendations. I think that they have pointed out the root cause of the problems. I think that we should enhance accountability of the senior management. And now the safety indicators have incorporated into the performance appraisal indicators of the senior management. I support that. And our public healthcare software is of high quality. And I also think that it's important for us to enhance the safety culture. The report said that young healthcare practitioners lack training. When experienced healthcare practitioners leave and there is a lack of succession, I think that the government should look into the reason why so many experienced healthcare practitioners are leaving the system. After working in Hong Kong or the hospital authorities for so many years, they should have built a sense of belonging. Why are they leaving? And I think that there should be honest and open communication. And a lot of frontline officers are afraid to speak up. Incident management, that's important. I think that there should be an incident reporting system. There should not be any delay. And I think that the training for spokesperson is also very important. Sometimes it's not about whether you disclose the incident, but if you don't have sufficient information and if there is misunderstanding, then there could be disaster. A good PR strategy is very important. Some healthcare practitioners told me that frontline workers have to work on a lot of administrative works, and so that they don't have time to take care of their patients. This is not mentioned in the paper. I hope that you can actually look into the issue. Healthcare practitioners want to take care of patients. They don't want to work on administrative duties. You can delegate such tasks to clerks. My question is very simple. The 31 recommendations are great. How do we make sure that they're duly implemented? Just now, the Secretary said that they will establish a reform committee, but how do Legislative Council members participate? Will you make a progress report to us? Secretary. Well, I will ask Dr. Ko to talk about how they are going to implement the 31 recommendations. Thank you, Madam Chair. As mentioned by Mr. Chan, I thank the review committee for giving us the recommendations. Some of them can be implemented very quickly, and we are working on that. Apart from creating a reform committee to look at the clinical management, we also have a plan to report on our progress in due course. when we have reached a milestone, we may come back to the Legislative Council. Mr. Chan, any follow-up question? Thank you. Please come back so that we can discuss it further. Mr. Michael Tian. Thank you, Madam Chair. Secretary, over the past 2 years, there have been multiple incidents within the hospital authority. There aren't many, but there are quite a few of incidents. 31 recommendations been set out in the report, but they are very broad. I'd like you to talk about 4 different things. First, management and accountability. You said that you will incorporate safety into staff appraisal assessment criteria to evaluate the performance of the senior management. I think this arrangement is particularly important to the maintenance director. Safety culture. You said that you will enhance the mentorship and supervision. Does that mean that you will ask an experienced doctor to review the procedures done by a more junior staff? Sometimes when there's medical incidents, you explain by saying that the task was carried out by a junior staff. And also, you said that you will adopt a risk-based approach to review the facilities. For wards or emergency and emergency departments, will you review the water supply every 6 months instead of every 12 months? Will you conduct spot check? Do you have enough staff to carry out spot check? Because now we're trying to check the checker. You said that you don't have enough staff to do that. Will the Labor and Welfare Bureau be able to import staff or labor? I just want this check the checker mechanism. It is mentioned in the paper that a reform committee will be set up, but there's not a timetable. Can you tell us if the committee will be established in 2 to 3 years' time? Will there be a centralized guidelines for all of the clusters? Thank you. Dr. Ko? Thank you, Madam Chair. Thank you, Mr. Tim, for the suggestions. I think that they are very important. There should be accountability for senior management. I agree with that. The members talked about repair and maintenance. We've looked at international practices. When we assess the performance of the hospital, we look at the infection rate and the antimicrobial situation and the maintenance of the facilities. We think that these are the right criteria for us to look into. We will also link the pay of the staff to the performance, but we have to work out plan and measure. Well, a safety culture is very important. Over the past few years, because of the pandemic, some junior staff lack clinical experience because of a school arrangement. For the wrong insertion of tubing. We have competency-based assessment to target these incidents. We will assess the clinical ability of our staff before we allow them to carry out such duty. We only allow them to carry out certain tasks only after making sure that they are able to do so. If they have any difficulty, we try to help them. Now on incident management. We've got some great suggestions from Mr. Tian in terms of facility management for places with high people flow, near the toilets or at the rooftop that is susceptible to water seepage. We adopt a risk-based inspection approach. We sometimes conduct inspection on facilities every 5 months. So we adopt a risk-based approach. As for the checker concept mentioned by Mr. Tian, we understand and we think that that's a great suggestion, and we will follow up on that. My last point on the guidelines for various clusters or the overall guideline. Well, for the overall plan, of course, all of the clusters have to abide by them, but each clusters have their characteristics. They serve population of different structure. As for timetable, we try to establish the reform committee as soon as possible. Roughly speaking, we will be able to implement the recommendations within a half-year time. When we have achieved any milestone, we report to the public and the Legislative Council.
局長有冇補充？
主席，我報一
Thank you, Dr. Ko. Professor Low. Just a comment on the last question about timetable by Mr. Michael Tian. We are always seeking excellence for health service, so the change will be continuous. There will not be a goal line for that. We will continue to implement the reviews recommended at the recommendations in the review. The review is quite comprehensive from the top level management to the cluster level. Now let me use another example to show Mr. Michael Tian how we are striving for continual improvements in excellence. For example, hospital assessment accreditation system. This is adopted by other countries as well. A third party would be engaged to audit whether a hospital is up to standard in terms of management and safety. Recently, we have introduced an international hospital assessment accreditation system. The Eastern Parmelia Hospital has passed the accreditation recently, and Prince of Wales Hospital is undergoing assessment. It shows that how we are continually improving our hospital system on the whole. At the hospital authority level, we have the Governance and Structure Reform Committee. So please rest assured, Mr. Michael Tian, this is not a one-off measure. We'll continue to review ourselves. I would like to praise Dr. Tony Cole. I've known him for a long time. This time, he never dodged a question. He has touched on all the points I asked, so I applaud him. Now, this meeting is supposed to end at 12:15. If there are no objections, there are still 4 members pending to speak. So I will extend the meeting until all members have asked the questions. Ms. Connie Lam. Thank you, Chair. Concerning the review on the review of the management of the public hospital system, I don't think this report is ideal. We know that there is a long-standing shortage of manpower in hospital, but among the 31 recommendations, I don't see any effective measures to effectively reduce the incident rate. Now, Professor Low said that we have introduced an international accreditation system. But how will that help in terms of reducing the occurrence of accidents? Besides the Governance and Structure Reform Committee, how can we prevent tragedies from happening again? Now, the report mentions that some spokespersons in the HA lacks training in information dissemination, and they are prone to cause misunderstanding in their speeches. It will weaken public confidence in the HA. Now, there are media reports that there is a 41-week-old girl who died during pregnancy. Now, there were accusations that the Tzit-yuen hospital failed to monitor the baby's heartbeat during pregnancy. So this is an example. Are there any instances where the public was misled by the spokesperson since they lacked training in information dissemination? Professor? I will answer the question first, and then Dr. Cole will talk about the accident rate. As I mentioned, overall speaking, within a highly complicated structure of the HA, we still have a rate of sentinel events or medical accidents much fewer than other jurisdictions. But one case is too many. If this happens to our family members, it would be greatly saddening to us. So even one case is too many. But we must understand that for institution of such a large scale, it is impossible to avoid medical incidents entirely. Now, about the issue with the spokesperson, it is mainly on communication skills. We emphasize that our spokespersons must be equipped with adequate communication skills in communicating with the public so that no further misunderstanding is caused, especially when an explanation is made to the family members of a patient. Whenever there is a medical incident, the family members will be greatly saddened and sensitive to words. So we must be very clear in our speech and in choice of words, and we must be communicating with great empathy. Now, about the incident rates, Dr. Tony Cole can elaborate. Now, about the incidents you mentioned just now, the hospital authority would convene a meeting and explain the incidents to the aggrieved family members. But we hope that patients' family members would not always resort to the media for judging the doctors. When there are any grievances about the decisions of doctors or hospitals, we can always engage a third-party expert to conduct an analysis to determine whether medical negligence is involved. Now, we need to nurture a trusting relationship between doctors and patients. Mutually, we can't always rely on the media to intervene. I stress that our medical system is of a very high quality. Dr. Cole, please. Chair, allow me to briefly address the question raised by Ms. Connie Lam. Now, the report says spokesperson require more training. As Professor Low said, communication is complicated when there are adverse clinical outcomes. It is of utmost importance we communicate the incident well to family members, the public, and other staff members. Misunderstanding may be caused if communication is poor. And also, medical procedures have become more advanced and complicated. Of course, it comes with higher risk, but also better outcomes. Sometimes adverse outcomes are really hard to be accepted by family members. Even though it is not a medical incident, it will still be very hard for family members to accept the adverse outcomes. Now, about the Tzit-yuen Hospital incident, after we have learned about the incident from the media, immediately we have collected information on the clinical case. Colleagues in the cluster have engaged experts. Preliminary findings are that the care provided to the pregnant woman was appropriate. Now, very often when a baby dies during pregnancy, there would be a lot of questions from the parents and also the family members. Very often, we need to conduct more investigation to find out the cause of the death of the embryo or the fetus. But we must understand that adverse clinical outcomes do happen. That is the same everywhere. The point is to communicate the incident well to the public, the family members, and our internal staff members to be transparent. On this, we think training is needed. Most of the time, we focus our training on medical training. So there's room for improvements in terms of communication skills. That's why we will follow up on this recommendation seriously. Next, Dr. David Lam, Deputy Chairman. First of all, some personal comments. I declare interest. I am also a member of the review committee on the management of the public hospital system. When a medical incident occurred, medical staff members would feel very sad. And the most important task is to care for the patients and family members. External influence would only pose unnecessary pressure on family members and the doctors. Now, in the review, I'm more concerned about the morale of doctors and nursing staff. Workload is a huge problem because it is very heavy. When workload is huge, every patient would get less attention from the healthcare staff. And when there is a lack of communication, it would give rise to misunderstanding. Frontline clinical staff members are worried whether they will be given adequate support in terms of clinical support and clerical support. Now, we have just restarted the hospital accreditation system, so clerical support is very important. I know the HA is going to step up clerical support for frontline staff. Once a medical incident happens, it would deal a dent to the morale to the staff and put more stress on them. Now, root cause investigation or root cause analysis often points to the lack of compliance with the guidelines. So usually the frontline staff would be put at the forefront of the blame. So we need to distribute the responsibilities better. It is not enough by only enhancing guidelines and supervision. On the contrary, it may add to conflicts between supervision staff and frontline staff. On the other hand, technology may help, but when we listen to the frontline staff members' opinions, the views are diverged. Some think they help, But some think that the current design of the system is not very user-friendly. It would be better if there is just one single system, but sometimes the HA would procure an external system from the private market to, say, monitor a patient's fall. So when there is an alert, you would have difficulty finding where the alert comes from. Sometimes frontline staff have to work overtime just for inputting the data. So there is much room for improvements between the management and the frontline staff. So these are actual difficulties faced by the frontline staff members. Now also, after the review is ready, a reform committee will be established by the HA. So I would like to know the structure, the work plan, and the terms of reference of this committee.
Dr. Ko. Thank you. After receipt of the report, we have kick-started our work. We're going to establish a reform committee to look at the governance, the accountability, and distribution of responsibilities and relevant reform work. When time is right, we will report to the LegCo more details. Currently, we are making preparation for the establishment. We cannot give you any further details as of right now. Next, Mr. Xiu Ka-fai. Thank you, Madam Chair. We heard about medical incidents, but it seems that our percentage is lower than other countries, but one incident is one too many. Within this year, I visit your public hospitals very often because some of my family members are in there. I see that your colleagues are very, very busy and they are extremely professionals. I'd like to take this opportunity to thank your colleagues sincerely. Given a manpower shortage, there will be more medical incidents. So I wonder how we can improve the situation. For training of local staff, the number is limited, but perhaps you should look into recruiting medical practitioners from Southeast Asian countries, say Thailand, and the Commonwealth countries. And I know that you are working on various areas. Your permanent secretary, Mr. Chen, said that you want to integrate the Western and Eastern Hong Kong Island clusters. I've been a district councillor of the Eastern District for some 10 years. There is a large population in the Eastern District, and there is aging issues because a lot of young people have moved out of the Eastern District. With the decline of population in the Eastern District, the people have become older there. A lot of Eastern District residents are worried about having to go to other districts to seek medical services. Secretary. Thank you, Mr. Xu. We have 7 clusters under the hospital authority. And that's based on the demand of service and the structure of population. We also look at medical innovations before we review and adjust the distribution. We have made adjustment previously. For example, 8 years ago, in 2016, the Kwong Wah Hospital and the Wong Tai Sin Hospital used to be in Kowloon West cluster, and now they are under Kowloon Central clusters. That's the adjustment that we made in accordance to the change in service demand. There is a lot of misconceptions. Some people think that we are killing off some of the hospital after integrating the Western and Eastern clusters. We never said that the Eastern Hospital will be subject to any form of change after the integration. After the Cornwall hospitals have been incorporated under the Kowloon Central cluster, the service is not changed and is now being redeveloped. We have added a large number of beds there, and the accident and emergency departments have expanded in scale. We conduct review and adjustment regularly. Now, on the integration of Western and Eastern clusters in Hong Kong Island, let me give you some figures. We have 7.5 million people. In 2041, there will be 1 million more people. We have 7 clusters currently. But the population in Hong Kong Island amount to 1.2 million people. So it can be served by one cluster. So we look at the overall population and the structure. In 2041, there should be 8.5 million people in Hong Kong. A cluster would serve 1 out of 7 or 1/7 of the population. So I think that is necessary for us to review and make adjustment. By integrating the 2 clusters, the Eastern Hospital services will not be affected. There could even be improvement because upon integration, the management and administrative efficiency will be enhanced. Through cooperation between the 2 clusters, the service can be enhanced. Take, for example, as there is a lack of manpower in the 2 clusters, some form of service, say the 24-hour service, are not up to par. Through integration, there could be coordination. In the Queen Mary Hospital, there could be staff that can help the Eastern Hospital to enhance their services. So integration does not mean that the Eastern Hospital patients have to go to the Queen Mary Hospital. Instead, the training offered by the Queen Mary Hospital can be shared to the Eastern Hospital. Thank you. I hope that you can continue with the expansion of the Eastern Hospital and add more bed spaces, and I hope that you can communicate with the stakeholders more often. Well, first of all, we must review the cluster first by looking into the population before we look into the expansion project. So the expansion project should come second to the cluster review. As for communication with the stakeholders, we don't just look at the Hong Kong Island. There is a great change in, for example, new territories. There will be a northern metropolis. We will look at all of the 7 clusters in Hong Kong. After coming up with the plan, we will publish it and communicate with the stakeholders. Mr. Chan, a permanent secretary, emphasized on the radio show that we are still at the review stage. Now it's my time to speak. I'd like to talk about management of public hospital. Frontline officers and assistants in public hospital work very hard, and they are very dedicated. They don't want any incidents with any patients. So here I'd like to thank the frontline medical practitioners. There are a few recommendations on management that I would like to ask about. First, every year, hospital authority receive increasing commitment from the government. In 2016-17, HA received some $534 billion. This year, they will receive $95.4 billion. In the report, it is said that from clusters to departments, the staff there have a lack of understanding of the accountability. We give you some $90 billion for enhancing your manpower. How come there is a lack of understanding of structure and functions of the head office, clusters, and hospitals? With some $90 billion of subsidy, why is there a lack of clarity and consistency among different levels of staff about their roles and responsibilities in relation to quality and safety? And there is a spokesperson training preparedness program. I see that you have dedicated much resources on training the spokesperson. Now you are proposing a spokesperson preparedness program to improve the effectiveness in public communication of incidents. Are you allocating extra resources to it? Or are you redeploying existing resources? Lastly, on cluster. We don't have much details. I know that you are not demolishing any hospital, but in 2019 you did say that in the second 10-year hospital project, there will be 500 daytime bed places. After adjustment, will these 500 daytime bed spaces in the Eastern Hospital disappear? Dr. Cole. We see a lot of great suggestions and recommendations in the report. Now, in terms of resources, now, we want to enhance our management and efficiency as well as cost effectiveness. We try to make use of existing resources to enhance the efficiency and effectiveness of our work as well as the clinical outcome of our treatment. That's why in the report it is said that there will be a comprehensive indicators. We look at the clinical outcome, the number of consultations, along with other indicators and metrics. You talked about medical fees. You said that, or the commitment in 2016-17, you said that we got some $53 billion. But with the medical advancement, we need different drugs, facilities. The requirements have become higher. With the higher cost, the clinical outcome has become better. We see that when an incident happens, everyone wants to fix it. Sometimes everyone gives their views, and that delay our response. So, say for example, if there is a medical incident in the future, we'll, in accordance with the seriousness of the case, we try to handle the incident as soon as possible. For less serious cases, we try to handle it at the cluster level. We should link accountability with responsibility. and that's the direction that we will work on. Now, on the spokesperson preparedness program, from a clinical perspective, when there's an incident, we ask the department chief to explain to the stakeholders internally and externally. The department chief may have worked in the department for some 30 years, but it could be the first time that they're answering journalists' questions. They could be nervous. We think that if there is a better communication, that would facilitate explanation of the case. For colleagues who have better communication skills, we try to train them. It's important for us to talk to our colleagues as well as external parties. Some colleagues try to blame themselves. And we agree with the recommendations that we should step up in this area.
Professor Low. Chair, allow me to elaborate on two of your questions. First, the usage of the yearly allocation of resources, $90 billion to take care of 7.5 million population in Hong Kong. More than 90% of our population rely on the public health care system. Now, $90 billion seem to be an astronomical sum. However, if you look at the current expenditures on healthcare percentage in our GDP, it is just 3.9%. That is quite low in the world standard. Over the past, we have been famous for the efficiency of our healthcare system and the cost effectiveness. $90 billion caring for 90% of the 7.5 million population with a safety network. That is actually very cost effective. But we do understand that the speed of increase in expenditure is worrying, but they are well justified. We have an aging population. We enjoy the longest life expectancy in the world. This is a strength, but it is also a burden on our healthcare system. And also, we are introducing the most advanced medical and health technology into our system. That's why medical costs has become more expensive. But we understand we need to do better. To do that, we need to address the imbalance in the healthcare system. That is, we need to incentivize the citizens to use our primary healthcare system so as to alleviate the burden on our hospital system. We will also avoid abuse. That's why we are going to review the fee arrangements for hospitals. Second, the discussion in the media that there may be a possibility of integration between the Hong Kong Island West and East cluster to adjust to the changing demographic structure. Now, the 500-day care bed is included in part of the second 10-year hospital development plan. Now, with the Northern Metropolis developments, there will be adjustments for a plan. So if there are any final adjustments, we will consult members when the time is right. But this is not the right time to make any judgment. Thank you, Secretary for Health and your team and the HA. That concludes this item. Item 5, any other business? Now, this meeting is the last meeting of this panel in this legislative session. I thank members and government officials for attending our meetings in the past year. There being no other business, the meeting is adjourned. Thank you.